Welcome to the deep dive. Okay, picture this. It's 2 a.m., the trauma team page goes off. That sound we all know.
Oh, yeah. Definitely know that sound.
And you, the resident on call, are heading down to face a complex multi-system trauma patient. This isn't just about, applying some hardware.
Not at all. It's about making these incredibly high-stakes decisions, life or death, limb-saving stuff, under immense pressure.
Exactly. So today, we're diving deep. We're opening up the foundational text. Think Campbell's, think the core literature to really pull out that practical, deep knowledge. The stuff that takes you from just competent to, mastery in orthopedic surgery.
That's the goal. This deep dive is really for you, the learner. We want to give you a kind of shortcut to understanding the why and the how behind managing these really tough trauma cases.
Yeah, we're going to synthesize info on everything from joint instability, shoulder, elbow.
And those complex fractures, pylon fractures, pelvic rings, elbow injuries.
Right.
Focusing on the biomechanics, the principles that actually dictate whether your fixation holds or fails.
Think of us as your guides through the trenches. I'm here to ask those questions, maybe the ones the textbooks kind of gloss over.
And I'll try to walk us through the decision points, drawing on the surgical principles, the material science, and those critical lessons learned the hard way. We're moving beyond just what to do to really understanding why and how.
Okay, we've got sources covering the big picture, systemic response, infection control, implant mechanics, soft tissue. Let's not waste any time. That unstable patient rolls in. What's the absolute first orthopedic principle guiding your thoughts?
It absolutely has to be life over limb, always. And, how we handle major fractures in a polytrauma patient, that's actually shifted dramatically.
Since when, roughly?
Really, since the early 1990s, we saw this big move towards early total care, or ETC.
Right, ETC. I know the idea is getting those big fractures fixed early. What was the driving force behind that shift? What were we trying to prevent?
We were really battling those systemic complications. The data started showing pretty clearly that early stabilization, especially for things like femur fractures, pelvic fractures, it significantly cut down the rates of ARDS, acute respiratory distress syndrome, and also fat emboli syndrome.
Nasty stuff. So the idea is fix the bone, stop the systemic hit.
Kind of. The hypothesis is that definitive fixation, getting a nail in or a plate on, quickly stops the ongoing release of inflammatory mediators and bone marrow contents into the system. So if a patient is stable, going ahead with ETC generally leads to better outcomes. We see statistically significant drops in morbidity, shorter hospital stays.
Okay, so stable patient go for definitive fixation or RIF, nailing pretty quickly. But defining stable in that chaotic trauma-based setting, that's the tricky part, isn't it?
That is the million-dollar question.
What are the red flags? What makes you immediately slam on the brakes for ETC and pivot to damage control orthopedics, DCO?
DCO is for the patient who is physiologically unstable, period. If they're in shock, hypotensive, severely acidotic, profoundly hypothermic, that lethal triad,
Right.
you absolutely do not proceed with a long, potentially bloody definitive fixation surgery. DCO is your rapid immobilization strategy.
It's like the orthopedic pause button, right? You accept maybe less than perfect alignment for now.
Exactly that. It's pragmatic, it's life-saving. You slap on an external fixator, quickly get stability, restore basic limb length.
Buys you time.
It buys you critical time. You accept you'll do the full evaluation later, maybe days later. Then you convert that X-fix to definitive fixation, like an IM nail or plating, once the patient is physiologically stable and optimized. It's about saving the patient's life first. Perfect fracture reduction comes second.
Makes total sense. And even for the stable ones, polytrauma patients, maybe ISS less than 18, and definitely the elderly,
Right.
early stabilization still has big benefits, right? Just getting them out of bed.
Absolutely. Fixing those major fractures, hip, femur, pelvis early on, dramatically decreases all the problems that come with being stuck in bed. Pneumonia, DVTs, skin breakdown. Huge benefits.
Okay, so from the big picture physiology, let's zoom right in. Down to the microscopic level, the war happening inside an open fracture wound. You said we switched from engineers to applied microbiologists here.
That's the crucial mindset shift, yeah. An open fracture is, by definition, contaminated. And classifying that contamination is step one. We rely on the Gustilo-Anderson classification. And you really need to know the differences, like what you see laid out in figures like 53.2 in Campbell's.
Okay, run us through the key distinctions. What separates a type I from a type 3?
So type I, that's your small puncture wound, less than a centimeter, pretty clean, minimal muscle damage. Think low energy. Type 2 is a bit bigger, over a centimeter, moderate soft tissue damage, but not extensive stripping.
Still manageable coverage.
Usually. Then you hit type 3, and the complexity just skyrockets. I3 means extensive soft tissue laceration or damage, but, and this is key, you can still usually get primary soft tissue coverage of the bone.
Okay. IIA, bad, but maybe coverable. What about IA?
IIB is extensive soft tissue loss, significant periosteal stripping, the bone is exposed, and you know you're going to need some kind of flap or complex soft tissue procedure later on. It's not closable primarily.
Got it. And the worst case, IHOUS.
IIS is defined by one thing, an associated arterial injury that requires repair. Doesn't matter how big or small the skin wound is, if the artery's out, it's an IA. That immediately tells you the limb viability is threatened and the risk of infection and amputation goes way up.
And once bacteria are in there, the real enemy isn't just the bacteria themselves, it's this fortress they build, the biofilm.
Exactly. If you look at diagrams of osteomyelitis pathogenesis, like
Yeah.
figure 53.9, you see this grim sequence. Contamination happens first. But the critical step is colonization, where the bacteria attach especially to dead bone fragments and start secreting this slimy protective layer, the exopolysaccharide biofilm.
Like a shield.
It's like an invisibility cloak and a shield combined.
Yeah.
Your own immune cells, macrophages, antibodies. They just can't get through it effectively. And the antibiotics we give systemically, they struggle to penetrate that biofilm matrix too. That's what leads to chronic infection, that dead piece of bone called a sequestrum, and often a draining sinus tract.
Okay, so if biofilm formation is the race against time, how crucial is getting those prophylactic antibiotics in?
It is arguably the single most important thing you can do, right alongside prompt surgical debridement. The evidence is overwhelming. Systematic reviews show that giving a first-generation cephalosporin, ASIP after injury, drops the infection risk by something like 59%.
Wow, that's huge.
It's massive. Time is tissue, time is limb. And we stick to the evidence. Short-course prophylaxis works. There's really insufficient data to back up routine, prolonged systemic antibiotics, or just throwing antibiotic beads into the wound long-term.
Unless maybe specialized bead pouches that you plan to remove later.
Exactly. Those are a bit different, more like a targeted local delivery system that gets taken out. But just leaving beads in, not really supported for routine use.
Okay, so early antibiotics, aggressive debridement, got it. Now let's talk about a specific soft tissue curveball that can really complicate things. The Morel-Lavallée lesion.
Ah, yes, the Morel-Lavallée. This is that sneaky injury, usually over the thigh or the greater trochanter area. It's caused by a big shearing force that basically rips the skin and subcutaneous fat off the underlying fascia.
A closed degloving, essentially.
That's a perfect description. It creates this potential space that fills up with hematoma and necrotic fat. It's avascular, and it's a perfect setup for infection if you operate through it unknowingly.
I feel like the old teaching was often just to wait and watch those. Is that still the thinking?
It used to be, mostly out of fear, I think. Fear of opening it up and devascularizing the overlying skin flap even more, because it's already compromised.
Makes sense. But waiting seems risky too, if it gets infected.
It is. The more modern approach, thanks to work by people like Seng and Tornetta, really favors definitive percutaneous drainage, especially if you catch it early, within the first few days. Get that fluid collection out.
Okay, drain it. But what's the key pearl then regarding timing your definitive fracture fixation, say, if there's an underlying fracture?
The absolute key is you have to wait until that drainage has slowed right down. The typical benchmark is less than about 30 milliliters per day coming out of the drain. Only then is it safe to proceed with your delayed ORAF. Going through that boggy, potentially contaminated tissue plane too early is just asking for a deep infection disaster.
Right. Gotta
Yeah.
respect the envelope. So section 1 really hammers home this balance. Systemic stability, first DCO versus ETC, then fighting the biological clock against infection with prompt antibiotics and debridement, and finally, respecting that soft tissue envelope, dealing with things like Morel-Lavallée lesions properly, control the clocks, manage the tissues.
Okay, moving from the big systemic picture and open wounds up to the joints. Here, we often shift focus to ligamentous issues, capsular problems, things requiring real precision. Let's start with the shoulder, specifically multi-directional instability, MDI.
MDI, that generalized looseness,
Yeah.
shoulder slipping out in multiple directions, usually treated arthroscopically now, right? Capsular plication, capsular shift.
Yeah, arthroscopy is definitely the dominant approach now. The big advantage is significantly less morbidity compared to the old open techniques. You're not taking down the deltoid, less thoracic tissue disruption.
But the open shift, where they literally overlap the capsule, that was pretty robust, wasn't it? How do we replicate that strength arthroscopically?
That's where the technology comes in. Open surgery allowed for that direct physical reinforcement. Arthroscopically, we rely heavily on suture anchors. Work by Bradley and others really highlighted how critical anchors are for MDI repair. They let us securely grab and tension that stretched out capsule, performing that shift or implication effectively, often addressing the anterior, inferior, and sometimes posterior capsule to restore that stability.
But here's the classic warning every resident gets drilled into them. Don't over-tighten it. Why is that such a critical error in MDI surgery? What's the long-term consequence?
It is the most critical judgment call you make in that procedure. If you get too aggressive, trying to completely eliminate any sulcus, making it rock solid, you fundamentally change how that joint moves. You restrict normal translation and rotation.
And that causes...
It puts chronic, uneven, abnormal stress on the articular cartilage. You basically guarantee eccentric wear and premature arthritis. You've traded instability today for a destroyed joint down the road. It's a terrible trade-off. We often focus on closing the rotator interval, especially for inferior instability. But the goal is always stability without stiffness, without undue restriction.
Finding that balance. Okay, let's pivot to rotator cuff repairs.
Yeah.
There's still that ongoing debate about impingement syndrome, right? Is it mostly extrinsic, the acromion shape, the ligament pressing down? Or intrinsic, the tendon itself degenerating with age, core blood supply?
It's almost always a bit of both, you know. The relative contribution just varies hugely from person to person. But from a purely technical standpoint, when you're in surgery and you've got a cuff tear, especially a big retracted one, and the tendon just won't. It won't come back to the bone easily.
Poor mobility.
Exactly. Poor supraspinatus tendon mobility. That's when you need to perform a specific mobilization step to get a tension-free repair.
What does that involve? What are you actually releasing?
You need to release the superior capsule, carefully dissecting in that plane between the undersurface of the cuff tendon and the rim of the glenoid. You usually start anteriorly, near the rotator interval, and carry that release posteriorly, sometimes all the way back to the base of the scapular spine. That frees up the tendon, lets it travel back to the footprint without being stretched like a rubber band.
Because a repair under tension is doomed to fail.
Guaranteed to recur. Tension is the enemy.
Okay, so you get a good tension-free repair. Now comes the rehab reality check. For a massive tear, and we're talking bigger than 5 centimeters here, right? The protocols, like in Table 52.7, seem incredibly strict in Phase I. How do you sell that to a patient who's eager to get moving?
You have to be blunt. It's non-negotiable. For those massive tears, they are immobilized. Sling, often with an abduction, ABD pillow, for a solid 4 to 6 weeks. And the protocol is crystal clear. No AROM would jeopardize repair.
Meaning absolutely no active movement by the patient, not even helping it along.
0. It's all passive range of motion, PROM. Usually done carefully by a therapist or maybe very gentle pendulum exercises instructed properly. That tendon-to-bone healing site has virtually 0 strength initially. Any active muscle contraction pulling on it will just rip the stitches through the tendon. If they cheat, the surgery was potentially for nothing.
Wow. But the progression happens later.
Oh yeah. Contrast that with Phase 2 goals by 8 weeks. You're often aiming for PROM up to maybe 150 degrees of forward flexion. But that initial protection phase is absolutely paramount for biological healing to even begin.
Okay, shifting joints again. Let's talk about the elbow, specifically elbow arthroscopy. It's notorious for being tricky because everything's packed in so tight. What are the big danger zones, the structures you're constantly thinking about?
You're operating in a very confined space with major neurovascular structures literally right next door. Posteriorly, for instance, if you're dealing with bone spurs, osteophytes, on the posteromedial side.
Yeah.
The ulnar nerve is right there. Sometimes it feels like it's separated from your shaver only by the thin joint capsule itself.
Yikes. And anteriorly?
Anteriorly, you've got the brachial artery and the median nerve. Laterally, the radial nerve and its posterior interosseous branch are at risk, especially near the radiocapitellar joint.
So how do you stay safe? What are the key preventative measures?
Meticulous setup is everything. Careful drawing of landmarks, constantly palpating the ulnar nerve's position. Keeping the forearm pronated during anterior work can help protect the posterior interosseous nerve. And critically, fluid management. Avoid high-pressure, high-flow pump systems. Stick to low-flow infusion, around 40 to 45 milliliters per minute.
Why low flow?
Because high flow can cause rapid fluid extravasation into the soft tissues. You can get compartment syndrome very quickly, or just swell the tissue so much it puts direct pressure on the nerves.
Right. And what about nerve issues just from positioning or traction? I remember seeing data like from Paulos and Franklin suggesting a really high rate, like 30% of temporary nerve symptoms, paresthesias after shorter scope traction. How do you minimize brachial plexus strain during elbow scopes?
Positioning is key. We typically use specific setups, maybe the shoulder flex forward about 45 degrees and abducted 90 degrees, or sometimes flex 45 and at 0 degrees abduction, depending on portal placement. The goal is to find that position that gives you good joint access and visualization without putting excessive stretch on the brachial plexus. You really want to avoid turning a temporary neuropraxia into something permanent.
Okay, let's dive into two specific elbow problems. Osteochondral defects, OCD, usually of the capitellum in throwers or gymnasts, and post-traumatic arthrofibrosis or stiffness. When does an OCD lesion actually need surgery?
We usually rely on classification systems like the one from Takahara and colleagues. It really comes down to stability and symptoms. Stable lesions may be just some flattening, the cartilage is intact, patient has good motion, maybe the growth plate physis is still open. Those can often be managed non-operatively.
And the unstable ones, what makes them unstable?
Unstable lesions are the ones needing surgery. That includes lesions where the physis is closed, you see actual fragmentation or loose bodies on imaging, the patient has significant motion loss, typically 20 degrees or more, or they have persistent swelling and effusion.
For those unstable defects, especially bigger ones in skeletally mature folks, why isn't just fixing the fragment back usually enough? Why do we often end up doing an osteochondral transfer, like an OTS procedure?
Because often that fragment isn't just cartilage. The underlying bone is frequently dead or too damaged to heal reliably. If the defect is big, say more than half the articular surface, or if it's causing mechanical catching because the radial head is hitting it, you need to replace it with healthy, living cartilage and bone.
Which means borrowing it from somewhere else.
Exactly. Osteochondral transfer uses an autograft plug, usually harvested from a non-weight-bearing part of the knee, like the intercondylar notch or the edge of the lateral femoral condyle. While you can sometimes harvest these arthroscopically, getting them placed perfectly flush into the capitellum, achieving that precise, smooth placement needed to restore the joint surface that often requires an open approach for the best accuracy.
Makes sense. Okay, last elbow topic. Arthrofibrosis. That stiff elbow after a bad fracture or dislocation. It's depressingly common. When you go in arthroscopically to release the contracture, what specific parts of the capsule are you targeting?
It's a very selective process based on what motion is lacking. If they can't get external rotation, ER, releasing the anterior capsule, and the rotator interval is key. If they're lacking flexion, FL, or maybe a combination of ER, FL, and internal rotation, IR, you often need to release the inferior capsule. For isolated loss of internal rotation, you target the posterior superior capsule.
So targeted releases. But even with careful technique, there's a known risk, right?
Right.
Delayed ulnar nerve problems.
Yes, that's a significant concern after elbow contracture release. Blana and others reported an incidence around 11% of delayed onset ulnar neuritis.
Why does that happen?
The thinking is that postoperative swelling, maybe some scarring around the nerve's path after you've released the tight capsule around it, can irritate or compress the ulnar nerve. If a patient develops new, rapidly worsening ulnar nerve symptoms, numbness, tingling, weakness after the surgery, it's an urgent situation. It might even require going back quickly for nerve decompression or possibly even a nerve transfer.
So because of that risk, do surgeons sometimes do a prophylactic ulnar nerve transposition at the same time as the release?
Many surgeons do, yes. Or they have a very low threshold to do an open release combined with a nerve decompression transposition, especially if the contracture is severe or if the nerve seemed irritable preoperatively. It's definitely something you have to counsel patients about beforehand.
All right, let's move down the kinetic chain to the lower extremity. High energy, high stakes, starting with one of the real tough ones. Tibial pylon fractures. These are just brutal injuries, right? Articular surface smash, soft tissues hammered.
Pylon fractures are incredibly challenging. They happen from axial load, basically driving the talus up into the tibial plafond, the roof of the ankle joint. And you're right, the management strategy is almost entirely dictated by the state of the soft tissues.
Which leads to the standard protocol.
A staged approach, almost always. Step 1 is temporary stabilization, usually spanning the ankle joint with an external fixator. This holds things out to length, provides some stability, and critically allows those massively swollen soft tissues time to recover.
And what's the clinical sign you're waiting for? The green light to go ahead with definitive internal fixation.
Skin wrinkling. That's the classic sign. When you see those wrinkles reappear on the skin around the ankle, it tells you the edema has subsided enough that your surgical incisions are much less likely to break down or get infected. You absolutely have to wait for the soft tissue envelope to declare itself ready.
Okay, the tissues look better. Now, what's the debate around how to fix it? Or IF versus maybe external fixation with some limited internal fixation.
That's the crux of the fixation debate. For simpler, lower-energy pylon fractures, maybe spiral patterns, traditional open reduction internal fixation, or IF, with plates and screws can work well. But for the high-energy, highly committed ones, the pendulum has swung more towards using combined external fixation with limited internal fixation, sometimes called LIFE.
LF, so keep the X-fix on, but maybe add a few key screws or a small plate through smaller incisions. What's the upside?
The big upside is a lower risk of deep infection and major wound complications. You're doing much less soft tissue stripping compared to a big formal ORAF.
Sounds good. What's the downside?
The trade-off is often a higher rate of more minor complications. Things like pin tract infections from the X-fix pins, which can happen in up to 20% of cases, or maybe issues with pin loosening, skin irritation around the pins, or problems related to those smaller incisions used for the limited internal fixation.
So it's a balance, but the ultimate goal remains.
The ultimate goals are non-negotiable. Get the joint surface as anatomical as possible and restore the overall axial alignment and length of the tibia. But you have to balance achieving that anatomical reduction against the absolute necessity of avoiding a wound breakdown or deep infection. Sometimes, a slightly less perfect reduction with healthy, healed soft tissues is a far better outcome than a perfect X-ray with an infected non-union requiring a flap.
Absolutely. Okay, moving up the leg to the hip. Femoral shaft fractures, most of them get a statically locked intramedullary. I know that's pretty standard, but let's focus on intratrochanteric IT fractures right near the hip joint. These have their own set of challenges. Which ones specifically push you towards using an IM nail instead of a side plate like a DHS?
The main ones are the unstable patterns. Specifically, the reverse obliquity pattern that's an AOTA type A3 and many of the comminuted A2 patterns where the posteromedial cortex is blown out. For those, an IM nail is biomechanically superior.
Why is that?
Because the nail sits more centrally within the bone, closer to the mechanical axis of the femur. It provides better resistance to the varus collapse and medialization forces that tend to overwhelm a side plate construct in those unstable patterns. The lever arm is just shorter and more favorable with the nail.
Gotcha. Now, regardless of whether you use a nail or a dynamic hip screw, DHS, there's this one crucial measurement everyone talks about for predicting success or failure. The tip apex distance, or TAD. Let's look at figure 55.32 in Campbell's. Explain why TAD is like the orthopedic surgeon's crystal ball here.
TAD is absolutely critical. It's simply the sum of the distances measured on both the AP and lateral x-rays from the very tip of the lag screw or hip screw to the true apex of the femoral head. Baumgartner's work back in the 90s showed this incredibly strong correlation. If your TAD is greater than 25 millimeters, the risk of the screw cutting out of the femoral head goes up exponentially.
So lower TAD is better. What's the ideal target?
Ideally, you want it under 25. Many aim for less than 20 or 22 millimeters. It essentially reflects how well-centered your screw is within the femoral head. You're aiming for that perfect center position to get the best bone purchase and minimize the risk of the screw migrating superiorly and cutting out.
Okay, besides TAD, another big focus recently in IT fractures, especially when considering a DHS, is the integrity of the lateral trochanteric wall. Why has this piece of bone become so important?
The lateral wall acts as a buttress. When you use a DHS, the system is designed to allow controlled collapse and compression at the fracture site as the patient bears weight. But that controlled collapse relies on the lateral wall being intact to prevent the proximal fragment from sliding too far laterally and medially displacing the shaft.
So if the lateral wall is broken...
If that lateral wall is fractured, either it was part of the original injury or, unfortunately, sometimes it gets fractured iatrogenically when you're prepping for the DHS plate, then it can't provide that buttress effect. You get uncontrolled collapse, excessive sliding, varus deformity, and likely failure of the fixation. It's like trying to lean against a wall that isn't there.
And didn't Pradeep and colleagues give us a number to watch out for? A thickness measurement.
They did. They published data suggesting that if the thickness of that lateral wall on the pre-op x-rays is less than about 21 millimeters, specifically 20.5 millimeters was their cutoff, there's a very high sensitivity and specificity for predicting that the wall will fracture if you try to use a DHS and achieve compression.
That's huge. So it helps you choose your implant before you even start.
Exactly. If you see that thin lateral wall preoperatively, it strongly pushes you towards using an intramedullary nail instead, because the nail doesn't rely on the lateral wall for stability in the same way. It's a great example of using pre-op planning to avoid a predictable complication.
Okay, let's tackle the big one in terms of immediate life threat: pelvic ring instability. These aren't just broken bones, they're often massive bleeds.
Absolutely. Pelvic fractures, especially the unstable ones, can lead to exsanguinating retroperitoneal hemorrhage.
Hmm.
We use classification systems like TILE or the AOTA system, but clinically, the first thing you need to identify is instability. We're most concerned about type C injuries, the ones that are unstable both rotationally and vertically. That means the posterior pelvic ring, the strong sacroiliac complex, is completely disrupted.
What are the quick radiographic signs that scream unstable even before you examine the patient?
You're looking for things like significant widening of the pubic symphysis, usually more than 2.5 centimeters. Also, avulsion fractures off the sacrum, like the lateral edge or off the ischial spine. Those indicate ligamentous disruption. And a sign described by Tun et al., the posterior iliac offset, where you can see the back part of the ilium is clearly displaced relative to the sacrum. These all point towards failure of those critical posterior ligaments.
And if you're still not sure about vertical instability after the x-rays, there's the push-pull maneuver, but you have to be careful with that one, right?
Extremely careful. It should ideally be done once under fluoroscopy, usually in the OR during an exam under anesthesia if stability is still questionable. You gently push and pull on the leg to see if the ipsilateral hemipelvis moves vertically relative to the sacrum. More than 1 centimeter of cephalad migration indicates vertical instability.
But you wouldn't do this in the trauma bay on an awake patient.
Generally, no, especially not vigorously. You could worsen bleeding or cause neurological injury. It's a test to confirm instability when needed, not a routine trauma bay maneuver if instability is already obvious or strongly suspected.
Okay, patient is unstable, potentially bleeding heavily. Let's walk through the hemodynamic stabilization protocol, like shown in figure 56.64. What's the immediate orthopedic move?
Immediate stabilization of the pelvic ring. This is usually done with an external fixator applied emergently, or more commonly now in the acute setting, a pelvic binder or sheet wrapped tightly around the pelvis.
And the crucial technical point about placing that binder.
It must be centered over the greater trochanters, not up high on the iliac crests. Placing it over the trochanters provides the compressive force needed to close down the pelvic volume and help tamponade bleeding. Putting it on the iliac crests can actually open the pelvis up more, making things worse.
Okay, binder on, resuscitation ongoing. If they still need massive transfusions, what's next?
If they remain hemodynamically unstable despite the binder and resuscitation, the next step is usually urgent angiography and embolization. Find the bleeding pelvic vessels and plug them. That's often the definitive step for controlling hemorrhage.
And a quick caution about those binders. They're life-saving, but
They can cause significant problems if left on too long or incorrectly applied. Major pressure sores over the sacrum or trochanters, even nerve palsies. They are a temporary life-saving measure and need to be monitored closely and ideally replaced with external or internal fixation as soon as the patient is stable enough.
all right, we stabilized the patient, managed the soft tissues. Now we got to put the puzzle back together. Let's shift into the engineering and material science side. First, the basics of the fracture healing engine. What does bone need to form? What are the essential ingredients?
You really need 3 core components for successful bone healing. First is osteoconduction. That's the scaffold or framework for new bone cells to grow onto. Second is osteoinduction. These are the signaling molecules, growth factors, that recruit primitive cells and tell them to become bone-forming cells, osteoblasts. And third is cellular osteogenesis itself. You need the actual cells, the osteoprogenitor cells that can do the work.
Got it. Scaffold, signals, and cells. Now, how does the mechanical environment, the stress on the fracture, influence how it heals? I know Carter's work, like in figure 53.13, is key here.
Yeah, mechanobiology is fascinating. It basically dictates the tissue differentiation pathway. The general principles are, if a fracture site sees intermittent compressive or shear stresses, that environment tends to favor endochondral ossification, meaning it forms cartilage first as an intermediate step, which then turns into bone.
Like how most long bones heal naturally?
Exactly. If the site sees primarily tensile stress, it tends to form fibrous tissue, instead not good for bone healing. And interestingly, if it sees constant compressive stress, that actually inhibits endochondral ossification and favors direct or primary bone healing where bone forms right across the gap, but only if the gap is tiny and the fixation is absolutely rigid.
So our choice of fixation rigid plate versus maybe a more flexible nail or bridge plate is actually dictating the biological pathway.
Precisely. We're deliberately manipulating the mechanical environment to encourage the type of healing we want for that specific fracture pattern.
But there's a paradox, right? We need to stabilize it, but the surgery itself causes more trauma.
That's the constant struggle. Every incision, every bit of muscle stripping we do to get to the bone risks damaging the blood supply, disrupting that crucial biology. That's why sticking to inner nervous planes, minimizing soft tissue disruption, is so vital. If you kill the biology around the fracture, even the best fixation might not lead to healing. You risk delayed union or non-union.
Okay, let's get into the hardware mechanics. The workhorse. The lag screw. Figure 53.22 shows the principle. Explain the core concept. Why does a lag screw create compression?
The magic of the lag screw is that it only engages its threads in the far fragment, the piece of bone on the other side of the fracture line. The part of the screw passing through the near fragment, the piece you're drilling into first, must act as a gliding hole.
Meaning the threads don't bite into that near piece?
Exactly. Because the near cortex hole is wider than the screw threads, the screw head tautens down onto the near cortex, but the threads only purchase in the far cortex. As you tighten the screw, it pulls that far fragment towards the near fragment, powerfully compressing the fracture line between them.
Okay, but often we're using fully threaded screws off the shelf. How do we make that near cortex hole a gliding hole?
You have to use the standard AO technique. You over-drill the near cortex. You drill the hole in the near cortex to the outer diameter of the screw threads. Then you use a smaller drill bit, the core diameter, for the far cortex. That difference ensures the threads only bite on the far side.
So it's like, maybe using a winch. The cable, screw shaft, slides freely through the near support, over-drilled near cortex, and only anchors onto the thing you're pulling, threaded far cortex.
That's a pretty good analogy. Like a winch pulling two things together. If that cable got stuck on the near support, you wouldn't generate nearly as much pulling force on the far object. Same with the lag screw. If the threads engage the near cortex, you lose almost all your compression. It just becomes a positional screw.
Got it. Okay, let's talk plates. They do different jobs, right? Compression, neutralization, bridging.
Absolutely. A compression plate, like a DCP, dynamic compression plate, is designed primarily for simple fractures, like transverse or short oblique type A shaft fractures. You apply it under tension or use the dynamic compression holes to actively compress the fracture ends together, aiming for that primary bone healing.
Okay. What about a neutralization plate?
A neutralization plate is used differently. It's typically used alongside lag screws, often for fractures with a wedge fragment, like a type B fracture. The lag screw provides the primary interfragmentary compression across the main fragments. The plate's job is then just to neutralize or protect that lag screw fixation from bending, shear, or torsional forces that could loosen it or cause the fracture to displace.
So the plate isn't the primary source of compression itself in that case?
Correct. It's protecting the compression achieved by the lag screw.
And then the bridge plate?
Bridge plating is for when you have a highly comminuted, unstable fracture, maybe with bone loss, where you simply can't get an anatomical reduction of all the pieces. The blade acts like an internal splint or bridge, spanning the cavitated zone, maintaining the overall length, alignment, and rotation.
And healing happens underneath it.
Yes, it relies on secondary or indirect bone healing via callus formation within that span segment. Because you're bridging a gap and relying on biology, this technique often absolutely requires autogenous bone grafting packed into the comminuted area to stimulate healing and fill the defect. The plate itself provides stability, but the biology has to do the heavy lifting across the gap.
Okay, and that brings us to the more modern locked plates. What makes these different, and why are they such a big deal, especially in weak bone?
Locked plates are a game changer, especially in osteoporotic bone or highly comminuted fractures, where traditional screw purchase is poor. The key difference is that the screw heads lock into the plate holes, usually via threads on the screw head, matching threads in the plate hole.
Creating a fixed angle construct.
Yeah, exactly. It turns the screw and plate into a single, solid, fixed-angle device. Mechanically, it acts more like an internal-external fixator. The load is transferred from the bone through the locked screw directly to the plate, bypassing the screw-bone interface, which is the weak point in osteoporosis. This dramatically increases resistance to screw pullout.
Makes sense. Okay, last bit on mechanics. Implant failure. Looking at those load deformation curves, like in figures 53.17 and 53.18, why do implants usually break post-operatively? Is it one big overload event?
Rarely. Overwhelmingly, implants fail due to fatigue. Think about it. That plate or nail is subjected to thousands, even millions, of small load cycles as the patient starts moving and weight-bearing, even partially. The implant is designed to withstand this repetitive loading within its elastic deformation phase that's the working area on the stress strain curve, figure 53.18, where it bends but springs back.
They can't do that forever.
Nothing can. Every implant has a finite fatigue life. If the bone healing is delayed for whatever reason, poor biology, infection, too big a gap, or if the fixation wasn't stable enough to begin with, those repetitive cycles eventually cause microscopic cracks to form and propagate, leading to fatigue fracture of the implant. That's why non-unions often present with broken hardware.
So as surgeons, we have to consider that fatigue life when we plan the fixation and the rehab.
Absolutely. You need a construct that's stable enough to last until the bone heals sufficiently to share the load. And the rehab plan needs to allow enough controlled stress to stimulate healing, Wolff's Law. But not so much stress that you exceed the implant's fatigue limit before the bone is ready. It's another delicate balancing act. #outro.
Wow, okay. We've covered a lot of ground. From those critical first decisions in the trauma bay DCO versus EPC through the microscopic battle against infection, the nuances of shoulder and elbow arthroscopy.
Right down to the nuts and bolts, literally, of screw mechanics, plating strategies, and why implants fail. It's a huge field.
So let's try to boil it down. What are the absolute key takeaway nuggets for the learner listening to this?
Okay, number one, soft tissue is king, always. Respect the envelope, drain that Marollo ballet, wait for the skin wrinkles on those pylons. Don't cause a bigger problem with your fixation.
Number two?
Number two, in the hip, especially IT fractures, know your numbers. That tip apex distance, T-DT, predicts cutout. That 21 millimeter lateral wall thickness predicts DHS failure. Use those measurements to guide your implant choice. Don't guess.
Got it. Third.
Third, match your plate to the fracture's personality. Is it simple and needs compression? Is it a wedge needing neutralization to protect lag screws? Or is it a mess that needs bridging and bone graft? Using the wrong plate function for the job leads to failure.
And fourth?
Fourth, maybe overarching. In any joint reconstruction, anatomic restoration is paramount, especially in weight-bearing joints like the ankle or restoring stability like the shoulder. Even small amounts of malreduction or residual instability dramatically increase the risk of poor function and long-term arthritis. Precision matters.
Excellent summary. So as we wrap up, what's the final provocative thought you want to leave our listeners mulling over?
Well, you know the old saying, good judgment comes from experience.
And experience comes from bad judgment.
Exactly. We learn from complications, unfortunately. But here's the thought. As our understanding of biomechanics gets better, as we identify these predictive failure points like the 21 millimeter wall, or the risk of arthritis from over-tightening a shoulder capsule, how much further can we push the boundaries? Can we engineer fixation, maybe combine it with biologics, to essentially guarantee functional outcomes? Even when the bone quality is terrible, the contamination is severe. That constant push to overcome biological and mechanical limitations to restore function against worsening odds, that, I think, is the ongoing story and the real excitement in the evolution of orthopedics.